Hi everyone, I'm happy and honored to be presenting on the topic of case formulation. I'll be touching on the research surrounding formulation and also discuss how my review of the literature on formulation led me to my current research project that explores the use of formulation in the practice of clinical psychology in Singapore. A little bit about my background. I come from Singapore and am currently pursuing my Masters in Clinical Psychology at the James Cook University campus in Singapore. This literature review on formulation is going to be part of my thesis, which I have to complete as part of course requirements. Towards the end of my presentation, I will also briefly describe my thesis project entitled The Use of Formulation in the Practice of Clinical Psychology in Singapore, which is currently underway. My supervisor who is supervising me on my thesis is Dr. Paul Fisher. So firstly, what is formulation? Well, there's basically no universally agreed definition of formulation. Butler, a famous and experienced cognitive therapist, has described formulation as a tool used by clinicians to relate theory to practice and a linchpin that holds theory and practice together. Formulations are a set of hypotheses that have to be tested. Formulation has also been defined as a process where therapist and client work collaboratively to draw on theory to describe and explain the issues that a client presents in therapy. A psychological case formulation has also been defined as an attempt to understand a patient's difficulties through a set of hypotheses about what happens in his or her mind and the links with the present and past experience and actions. Dudley and colleagues defined formulation as a process in which unique client experience is blended with a psychological theory or model with the purpose of understanding the origins, development, and maintenance of a presenting problem. Across the many definitions of formulation, similar themes consistently stand out. These include the use of psychological theory in formulating, formulations as being a hypothesis or set of hypotheses, and not as a set of unchangeable truths, formulation as a way that draws links between the past, present, and future in order to explain problems, and lastly, formulations are collaborative in nature. Both therapist and client bring their respective knowledge and expertise together to describe and explain the client's presenting issues. The formulation is developed in collaboration with the client and not independently from the client. Fundamentally, formulation is a way of understanding and making sense of the client's insurmountable problems, a way of using psychological theory to explain problems in light of a client's current life situation and context. Formulation helps to normalize a client's problems such that these problems do not seem so overwhelming and difficult to deal with. In the words of Liming and colleagues, if particular thoughts or behaviors make sense as a consequence of a person's history and current set of circumstances, then there is perhaps less reason for them to appear shameful or to confer a deviant identity. So why formulate? What are formulations used for? There are many purposes which formulations set out to achieve, but I will briefly mention key ones here. Formulations have been described as an overall picture or a map of a client's problems. After an assessment of the client, the psychologist is faced with the task of organizing all the information together in a way that paints the picture of and explains the client's problems. A formulation helps the psychologist to identify if important gaps of information are missing, which would help him or her to develop a coherent picture of the client. In and of itself, a formulation is not useful if it does not lead to something productive. Formulations are used to help the psychologist in planning and selecting interventions and prioritizing issues and problems with the client so that goals can be set and the client can work towards the goals. In such a way, the formulation provides transparency for the client as the client is able to make links between their presenting problems and treatment decisions. Formulations can also be used to identify medical interventions that might be needed and to predict client responses to interventions. Another important purpose of formulation is to help the client to feel heard and understood, through the formulation and to provide the client with a sense of hope that there is a solution to his or her problems. Formulation isn't exactly a new concept. It probably dates back to the 18th century when Freud described that his patient's case history read like short stories. While Freud did not use the term formulation, his case histories certainly had that flavor. Formulation also has links to the scientist-practitioner model, which is the recommended model of training for clinical psychologists, in which clinical practice has to be supported and informed by theory that is based on empirical research. In the 1950s onwards, psychologists in Britain used formulation to promote professional autonomy and separation from psychiatry. While diagnosis was the domain of psychiatry, formulation became the cornerstone of clinical psychology. Around the same time, formulation also became an integral part of practice for clinical psychologists in America. Although the term diagnosis was used, elements of formulation was clearly apparent in the statement from the APA, which emphasized that diagnoses are the investigation of the origins and dynamics of the presenting problems and hypotheses about outcomes. The term formulation was subsequently coined in 1969 when it was included in clinical psychology regulations and emphasized as a core competence of clinical psychologists, along with assessment, intervention, evaluation, audit and research, personal and professional skills, communication and teaching skills, service and delivery skills, and other transferable skills. Formulation from a behavioral approach had its origins in the 1950s at the Maudsley Hospital, where clinical psychologists Einstein, Mayer, and Turkett used principles of operant and classical conditioning as alternatives to diagnosis. They described and explained problem behavior in terms of environmental stimuli and response contingencies. In the 1970s, Aaron Beck included the role of thought processes to behavioral analysis to explain the development and maintenance of mental distress. Dysfunctional thought processes or beliefs of ourselves, others, and the world are thought to negatively affect our emotions, physiology, and behavior. From its inception, CBT has been established as a system of psychotherapy with solid empirical foundations. Outcome studies have shown that CBT is an effective treatment modality for many disorders and can be used across different populations ranging from the young to the old. The process of formulation in CBT has been described as a glue that holds the information about our client's presentation and the evidence base together. As mentioned earlier, psychodynamic formulations have their origins in Freud's case studies, where he drew on concepts of the unconscious, transference, defense mechanisms, the id, ego, and superego, and used these psychoanalytic concepts to explain symptoms as having a symbolic meaning and as addressing a functional need. Although psychodynamic theory has been controversial for many years, as the concepts are difficult to evaluate scientifically, attempts have been made to evaluate psychodynamic formulations in recent years. The concept of working hypotheses has been key to the practice of family therapy from the late 1970s. Systemic approaches are concerned with using social and relational factors to explain how an individual or family came to have problems. These working hypotheses about an individual or family are often judged based on their usefulness to bring about change rather than taken as the truth, as proponents of systemic ideas often believe that there is no one way of viewing a family. Hence, these working hypotheses are open to being revised with the addition and insight of new information or ideas. In summary, formulation is an important element in the practice of clinical psychology. Although its roots could probably be traced back to Freud, who was a psychiatrist, formulation has become a cornerstone in the practice of clinical psychology, where clinical psychologists draw on various psychological theories to describe and explain their client's problems. Formulation is also a process where therapist and client work together. The client brings his or her expertise on himself or herself, while the therapist brings his or her knowledge of the evidence based in psychology to collaboratively explore the meaning behind the client's problems. Finally, and perhaps most importantly, formulations guide interventions. It is a roadmap which provides the therapist and the client with directions on how problems could be solved. In contrast to formulation, medical diagnosis is considered the pillar of psychiatry, and there have been ongoing debates about whether formulation differs from psychiatric diagnosis and whether it is an alternative to diagnosis or whether it could complement diagnosis. Diagnosis has its roots in medicine, of which psychiatry is a specialized field. In medicine, diagnosis has been defined as the process of determining the nature of a disorder by considering the patient's signs and symptoms, medical background, and when necessary, results of laboratory tests and X-ray examinations. Such a definition of diagnosis in medicine raises issues of the validity of diagnosis in psychiatry. Diagnosis in general medicine and diagnosis in psychiatry appear to be quite distinct from each other. While diagnosis in general medicine is concerned with clarifying the nature of a disorder, psychiatric diagnosis, as conceptualized in the DSM, which is a manual that contains categories of psychiatric diagnoses, is a descriptive approach that attempts to be neutral with regards to etiology. This means that psychiatric diagnoses are descriptive categories that are not particularly concerned with the origins or the causes of mental illness. Also, while general medical diagnosis is concerned with physiological signs and symptoms, an emphasis on signs and symptoms is absent in psychiatry, which largely relies on behavioral interpretations and judgments for diagnosis. This is why the indicators of mental disorders in the DSM are referred to as diagnostic criteria rather than signs or symptoms, although it has to be highlighted that there is not a strict distinction, as diagnostic criteria are sometimes referred to as symptoms in the DSM. However, it can be argued that if physiological signs or symptoms were present and can be sussed out by laboratory tests and X-rays, then these would be evidence of organic diseases rather than mental disorders.